Good morning, Gary McDaniels. This is Atlas Psychiatry's Deep Dive. How are you?
Good. How are you, Dr. Pejic?
I'm doing pretty well, pretty well. It's a fine New Orleans morning here in November, so I'm grateful to be with you this morning. Today we're going to be talking about EMDR, and I want to tell our listeners a little bit about you. You've been practicing for over 30 years, I believe, correct?
That's right. Correct.
Okay. So you are a master of masters, and we're so lucky to have you on our team.
Let me make it clear, though, that I have not been practicing EMDR for 30 years.
Right. Well,
EMDR has barely been around for 30 years, but I have been practicing trauma therapy for over 30 years.
Well, how about we talk about what EMDR is, and then you can give us some history about when it began. And so tell me, what is EMDR, and what is it used for?
EMDR is one of only 2 evidence-based trauma treatments by the World Health Organization. The World Health Organization says there are 2 best practice evidence-based trauma treatments: trauma-focused CBT and EMDR. That's it. The Bureau of Veterans Affairs acknowledges 3, which is also a form of CBT, a form of trauma-focused CBT, EMDR, and also exposure therapies. Right?
Okay.
So when it comes to treating trauma, EMDR is the preeminent trauma therapy. And I say that because it's so much, in my experience, more powerful, faster, less painful, with less complications than any of the other trauma therapies that I have used, which are quite a few. I've learned a lot as I've gone along.
And when you say trauma, can you talk about, to anybody listening, what exactly trauma is and all the different types of trauma that one might endure?
Okay, well, I'm gonna stay within, since we're talking primarily about EMDR, I'm gonna stay within the framework of EMDR. Okay?
Sure.
So there is a textbook definition of trauma. There's a DSM definition of trauma. But Francine Shapiro really preferred the dictionary definition of trauma. And that is anything that has happened to us in the past that's still affecting us negatively in the present and affecting our ability to function, live life, go to school, be married, have kids, have friends, have fun, live our life.
So anything that's happened to you in the past that's interfering your current life, and also
it's preventing you from moving forward in a good way.
And who is Jean Shapiro then?
Francine Shapiro.
Oh, Francine Shapiro.
Francine Shapiro is the psychiatrist, the person who created EMDR. And it really came out of a personal need. She was diagnosed with cancer. It was the 1970s.
Oh, wow.
She was really struggling. Cancer treatment back then, I'm sure you could talk more elegantly about how kind of harsh it was. She was really going through a lot. She was out walking, just trying to deal with her own anxiety, and noticed that as she scanned, when she was thinking about the thing that was troubling her, if she was walking and kind of scanning, that the troubling thoughts, or what we call the subjective unit of distress, lessened.
Okay.
She said, okay, that's interesting. Let me try that some more. And it worked. And then she tried it with some friends, and it helped them. And so she did a clinical study, and it was a fairly small one at first, but people were helped at a rate that was unanticipated.
Okay.
And so in the beginning years of EMDR, she started to push this out and train other people, because she felt like this is really powerful. This is a powerful treatment for a condition that we don't have many good treatments for, right? At the time, there was no FDA-approved medication. There were no good treatments. A lot of people suffering, especially post-Vietnam. And so she really started pushing this out. And as she did, she learned more and more, and more people got interested in it. But a lot of people thought, like, that's too fast. It seems too like magic. It's too much like a Jedi mind trick. that it can't be real. There's just a placebo effect going on here or something. So there were a lot of critics, which was a really good thing because it caused a lot of people to do a lot of research from different disciplines, perspective, angles, and they all came up with pretty much the same conclusions. This is a really effective treatment that works very quickly. So by the late 90s, the Veterans Administration had approved it as like one of the evidence-based practices. By the early, no, I think that was probably the early 2000s that the VA approved it. I think it was like 2013, 2014 that the World Health Organization approved it as one of the only two. So it's been some nice history of research and development, and it's gotten pushed out in a really good way because Francine Shapiro was really clear about wanting to always be have fidelity to the model, right? So she, because she was teaching other people, it really kind of forced her to think through, okay, what is this that we're doing and exactly what is it that's working, and to coordinate with a lot of other researchers and scientists and whatnot. So she ended up developing an 8-stage model.
An 8-stage model. So it's like 8 sessions, or what does that mean?
It's 8 distinct stages of treatment.
Okay.
When people think of EMDR, very often what they think of is just the eye movement.
Right.
Right. And that is a sliver of it. Like it's what she started with the name. She started with the name EMD, eye movement desensitization. That was the initial name. And she kind of wishes in retrospect that she hadn't called it eye movement, that she had named it something fuller. Because there are other forms of eye movement therapy that are not EMDR. So EMDR always contains these 8 stages.
Can you talk a little bit about the other stages?
Yeah. So the first stage is just what we always do. It's just the history. We take a good solid history. You know, we don't treat people without really understanding the problem. Once we really understand the problem, then we develop a treatment plan.
So you make sure that they actually have trauma of some sort that
is treatable by this process, and that they don't have any exclusions.
Which would be like what?
Well, for instance, if, you know, whenever we access trauma, it has a physiological effect, right? Now with EMDR, we don't have to access it very long. We don't have to access it in great depth like we do with the other processing, more like talk therapy ways of processing it. So we don't have to hit it as hard or as long, or it doesn't take as long to unpack. We don't have to go through all the details, but you can't treat the trauma without touching the trauma.
Okay.
And so this, it's a little later on in the stages, but I'll go ahead and talk about it now. It's when we're actually starting to do like the target planning, or what they call the assessment phase, where we're asking them to think about the event. And then we're also asking them to feel the emotion that goes with the event, because that's often what's stuck, is that emotional stuff. We ask them to think about the thoughts that go with the event. We ask them to think about the underlying belief that they hold about themselves as a result of the event. Like, for instance, someone dies and we say, it's my fault. And it's not, like you weren't even there, right? So So we ask people to collect all these bodily sensations and thoughts and feelings and beliefs, and a picture that is really uncomfortable. It's uncomfortable for a minute because we're able to desensitize it very quickly. But so if someone, for instance, had a really a heart condition where they were, you know, needed to not be upset, or, you know, you would clear it with that person's cardiologist. Or
so you're saying exclusions would be that type of thing, or if somebody was like using a substance or something where they couldn't access their trauma. Or
where they just are their life is so chaotic, they're still in all the trauma, they're, you know,
that they're not prepared to for that treatment. Now let's talk about,
which is why the second phase is preparation.
Okay, so preparation, yes.
Yeah. So after you do the history, then you do preparation, which we also sometimes call resourcing. Basically, we're teaching them some tools and skills for managing their own emotional regulation, so that as we go through the trauma therapy, if something really flips their switches, they have a way to contain it. They have a way to go to their safe place. They have some tools for calming their central nervous system. We often teach them breathing techniques, bilateral tapping techniques.
So you're doing all of that preparation before takeoff?
Yes.
Yeah.
So this is all the EMDR process.
And this will happen over 1, 2, 3 sessions before you even do the EMDR, or excuse me, the eye movement component of EMDR.
That's right. That's right. And this preparation part also includes like explaining to people what EMDR is and why we use it and how it works, because that's really what informed consent is, right? It's not just signing a piece of paper. It's really understanding what you're signing up for.
Absolutely.
So that's part of the preparation process too. These are the stages. This is how it works. This is what it feels like for a lot of people.
Yeah.
Et cetera.
Absolutely.
So when we see that they're well enough resourced, they have enough support, they have enough skills, they have enough ways of calming themselves down, then we do what Francine Shapiro called assessment. The term that Roy Kiesling, which is the person that I learned from, Roy Kiesling and Carol Lovell, a little shout out to them. They were amazing.
Shout out. Let's do a little heart to them.
Yeah. Carol Lovell and Roy Kiesling.
There we go.
Yeah. Roy Kiesling is one of EMDR's master trainers. And Carol Lovell was a new trainer. So you can kind of rise up through the ranks from being just a practitioner to a trainer to a consultant to et cetera.
Okay. So the assessment. You said the assessment phase. So tell us about that.
So this is where we're doing that target planning thing I was talking about, where it's like, okay, tell me about the event. The thing is, you don't need the whole novel. You just need the title and the back little description. Like, so what other forms of therapy, you're like going through all the pages and all the details and all this stuff. I just want a snapshot. I just want like, okay, it was the time that I got beat up in an alleyway.
So it's the bullet point without the paragraph behind it.
That's right.
They're telling you. You're cueing them to think about it.
I'm cueing them to think about it.
Okay.
Right. And I know a little bit about it. I know enough about it just from our history of kind of like where it sits. Right. So I'm asking them to think about it and feel the feelings that go with it and the thoughts that go with it and the old stuck belief that goes with it. And then I'm also asking them to do a really important thing, which I'm going to use a little later. And that is, I'm asking them, okay, we take that old stuck belief, right? It's my fault. I'm a loser. I'm stupid. I can't. I'm not good enough. I'm not pretty enough. I'm not skinny enough. I'm a mean person. Whatever it is, whatever the old belief is that's like causing us pain, we ask them to construct a more adaptive belief. And by more adaptive, we mean more helpful and more true. More true. It's got to be more true or you won't believe it. So like that old movement kind of back in the 80s that, SNL would lampoon about like, I'm pretty enough and I'm good enough. And like
Stuart Smalley.
Unless we really, Stuart Smalley. We won't believe it and it won't land unless it's true.
Yeah.
Like EMDR will not convince anyone that something that's not true is true.
So you help walk them through that process. And then does the eye movement part happen in the assessment phase or is that like afterwards?
Right after the assessment, while they're feeling all their feels, we have them scale it. Scale of 1 to 10, how distressing is it? 10, worst feeling ever. 1, I really don't care. Right? So we have them scale it. And then we very quickly start the dual stimulation. Now, dual stimulation can be eye movement. I'm asking you to literally follow my fingers back and forth. And I'm going to speed it up because I want to get kind of to replicating REM sleep, which we'll talk about a little bit further on, but it's some of the kind of the science underpinning why this works. So that's one form of dual stimulation. We also use tapping. Sometimes the therapist, with consent, of course, taps on the patient's knees. Sometimes people aren't comfortable being touched. They tap their own knees.
Yeah. Yeah.
You can also do it with the ears. You can do
sounds.
Tones. Yeah, sound. And there's some technology, assistive technology, if you choose. Like there are light bars, and then there are these little like buzzy things. They're called paddles that do like a little stimulation on this hand, like a zzz, 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 and then people can adjust the intensity and adjust the speed.
It engages the brain through other inputs, and you think that helps them do the reprocessing part of the information, the traumatic information.
What Francine says, once again, I'm going to stick within that paradigm. What Francine Shapiro says is she calls it the adaptive information processing system, right? Like our brain, just like the rest of our body, is built to metabolize whatever information, whatever sensory inputs come in from our environment, right? We eat food. Our body is designed to extract the good things from the food and eliminate the things we do not need.
Yeah. Right.
You get a splinter in your hand. If you can pull that splinter out, then your immune system is going to go do all the stuff it does. You don't even have to think about it. It's just going to do it. Most of the time as we go through life, things that happen to us, sometimes they're terrible, sometimes they're great, sometimes they're mildly crappy, whatever. Our adaptive information processing system in our brain does the same thing with. It hangs on to what it thinks is important, and it eliminates what it believes is not important. And there's a lot of stuff going on in there that would be a whole nother deep dive that you could better explain than I could about all those neurotransmitters and how that's all happening. But so she says that it's kind of like that trauma, that traumatic memory that's still pushing us around. It's kind of like you got the splinter in your hand and you put the antibiotic ointment on it, you put the Band-Aid on it, but it's not healing because you didn't take the splinter out. The splinter got stuck in there. So you're going to have to pull the splinter out, after which it'll heal on its own.
And pulling the splinter out, that's pulling the trauma out and reprocessing it and like perspective taking.
Yes, it is eye movement desensitization. It is desensitizing all that effective kinesthetic, emotional, intellectual response we're having to this thing that's stuck in our hand, right?
And I think it needs to be said too, folks who have had trauma, they avoid the trauma.
They avoid anything that reminds them of the trauma.
Yeah, so you have these folks who have had trauma in the past, and for years they just haven't dealt with it. They've kind of packaged it away psychologically, right?
Right. And this is where I'm going to get to your earlier question about the different kinds of trauma, right?
Yep. Okay.
Francine Shapiro talked about two kinds of trauma. She talked about big T trauma, which she considered war, natural disasters, sexual assaults, loss of a first-degree relative.
Yes.
Those are big T traumas. Like just that one thing is enough to just blow you out of the water.
Absolutely.
Right. But she also talked about the little T traumas. And remember, this is kind of like, as Francine is developing this, kind of towards starting to be more understanding of like how those early childhood traumas affect our growth and development, right? So she's also talking about little T traumas, all the stuff that happens usually when we're kids that piles up over time. But it also, sometimes if someone's in a domestic violence situation or someone has a chronic illness or all kinds of things can lead to that kind of piling up.
Can you speak to the little T traumas in childhood and what that looks like for folks often?
Well, there's a great study that was done about 20 years ago called the Adverse Childhood Experiences Study. And I would encourage anyone to look that up. These two physicians, Felitti and Anda, were both seeing the same thing, which was a lot of intractable obesity in men. And it turns out, as they started looking at, had experienced sexual abuse as children.
Wait, say that again. Intractable what?
Obesity.
Obesity. Okay.
Yeah. And so they got real curious about why are all these guys who are like, by intractable, I mean, they had tried all the treatments, like stomach stapling, everything, and they still gained the weight back. Like, what's going on? And the only thing that they could really find was this history of sexual assault in childhood. And so the one doc goes to a convention of doctors and presents his findings, and everyone thought it was ridiculous, except for the guy from CDC, Dr. Anda, who says, wait a minute, I'm seeing the same thing. You have patients, you work for Kaiser Permanente, I have money and research protocols, I work for the CDC, let's put this together. And they did, and they ended up with an N of like 13,000 people or something who completed these exhaustive surveys. And when they winnowed it all down, there were 10 things that commonly happen in childhood that create a dose-dependent impact on later health, and not just later mental health, but physical health. They were finding correlations to obesity, diabetes, heart disease, stroke, all the things that lead to early death.
And so in childhood, the types of trauma that they were having were what? They were sexually
yeah. It's things like physical abuse, sexual abuse, witnessing domestic violence, feeling invisible, not being cared for.
But that's a little T trauma, feeling invisible. I often see that when we evaluate patients, they won't consider those things traumatic until you really engage them in the conversation and it unfurls. So feeling invisible,
we have them do that ACE screen as a part of their clinical intake. Right. So you look at the number of ACEs, because the more ACEs, the more problems are likely to spring from those.
Yeah, it's an interesting thing, because a lot of times patients won't verbalize how bad their childhoods were when even asked. And then when we look at the ACE form that they checked off, because it's kind of factual, was anybody imprisoned when you were growing up? Or did you witness a parent being hit?
Did you live with an addict or alcoholic?
Yeah.
All these things that commonly happen to kids, right?
Yeah, I think it's so helpful, because you go, well, this patient didn't even tell me these things verbally, but when you look at the ACE, you're like, wow, this is clearly informing us about what this person went through, and is likely part of the reason why they're having difficulty today.
Right. Right. And of all those adverse childhood experiences, the physical abuse, the getting screamed at, the getting sexually assaulted, the someone going to prison, watching your mom get hit, all those things, there's only one that has an outsized impact. Like all of them are equal except one. And as an adult, I would think like that would be like sexual abuse or physical abuse or something. But in fact, it's the neglect one. It's the one about feeling invisible. Has an outsized impact, because even a bad attention is attention.
Yes.
Nothing isn't anything.
Yeah. Well, it reminds me of the study, I think, is it the Eastern European babies during World War II?
Their brains were literally smaller. And
they weren't nurtured, all kind of neglected, and physiologically it had major impact, psychologically. Right. That's fascinating. Right. So
this treats both of those kinds of trauma, the big T trauma and the small T trauma. Of the two, it's actually the big T trauma that's easiest, and often responds to just a couple of EMDR sessions. Like someone's in a car wreck and you do the history and you teach them a couple skills and you do a couple rounds of the bilateral stimulation, however you're doing that. And they're back in their car driving.
Yeah, and that's what I find fascinating with the patients that you've treated here. It's a briefer engagement. It's like unlike other therapies, maybe supportive, where you're going for months or years to a therapist to work through things for support. This really gets to the heart of the matter and helps treat it rapidly, which is a blessing for these folks. Now, given that, though, why don't you think that more people know about it, or hasn't have it be more available in the community? Because I know a handful of people that may do it, but it's not many patients have no idea what it is when I discuss it with them.
Yeah. Yeah, I am not really sure. Like, Bessel van der Kolk, who's kind of one of the leading lights luminaries in the treatment of trauma these days. He talks about it all the time. Gabor Mate, who's one of the leaders in the treatment of addiction, talks about it all the time. The VA, it's, you go to the VA, you'll find people who do EMDR. Like, it's one of their approved things. They want all their people trained in that,
Right.
So, but I think part of it is, like, if you look at those adverse childhood experiences, 70% of Americans have at least one. I think sometimes we're like fish swimming in water. Like, we've all been so traumatized by so much that we almost just ignore it because it seems too big to deal with. And then people encounter EMDR, they come in afraid, like, oh my God, here we go again, trauma treatment. I don't know if I can use it.
Right.
You said, no, seriously, go see this guy. This is going to help. And so they have confidence in you. So they come to me and they're like, oh no, not another trauma treatment. This is Then we do a few sessions and they're like, oh man, why didn't I know this 20 years ago?
Absolutely.
So it's like anything. It's really only been established for about 20 years, I think. The EMDR International Association, has been overseeing this thing, and that evidence-based thing from the World Health Organization, that's a decade. It just takes time for new developments to filter out. And the other thing is, you got to take a week out of your life and you got to go and do like a solid week of training, which is not just learning the techniques. You learn the techniques, you practice the techniques on a partner who's also a physician, and then they practice the techniques on you, right? It's just very immersive. You're not going to just go and sit in the back and eat bagels and doodle. I mean, you're going to be engaged.
Right. You're doing the work.
And then you have to do like 6 months of follow-up phone calls and staff cases, and it's expensive. So
what is EMDR not indicated for? Because I do see it sometimes used for things that you haven't discussed. So what did you say it's not indicated for?
There are, it's one of those things, like you can't claim certain things, right? Like, you can't claim that this cures that. But if you read Francine Shapiro's book, you'll hear about all kinds of cases that she's treated. Like, there are a lot of them are veterans, and a lot of them are people in a sexual assault. Those were kind of the early obvious places to get started. But she talks about, for instance, treating a woman who was unable to get pregnant. And of course, she encouraged her to go do all the physical things, but none of the physical things worked. They started EMDR, she got pregnant. She'd been trying for 10 years. Even the in vitro hadn't worked. Like, it's, no, you can't make that claim. You can't make that claim. But
was that person traumatized? Was that person traumatized? And in the EMDR is the patient in that case, are they evoking?
It was a case of
that's trauma, or what?
It was a case of iatrogenic harm. It was a case of this person was made to go see a psychiatrist as a part of her employment. She had been sexually abused in childhood, and this was starting to come back. And the psychiatrist said, well, don't have kids. People who are sexually abused in childhood abuse their children. And she believed it, and she argued and was convinced, and that had stuck in her. And it took a while to work their way back to that, because it was really, like, it wasn't something that was top of mind for her. It was something that happened that had really influenced her, and she had just tried to forget about it. And then later in life tried to have children and wasn't able to. And so, and Francine Shapiro won't say EMDR cured this woman's infertility, but it is interesting sometimes how even health things clear up. But when we understand that ACE science, then it makes a little more sense. Like, I've had a lot of people who are in like chronic pain and that had been in chronic pain since a traumatic event. And they'd had their chronic pain treated in pain centers and, all those different kind of ways. And then they go through this whole process, and that constant pain they've had in their neck and shoulders for the last 5 years is not there anymore.
Well, let me ask you about the depression side of things, because with the diagnosis of PTSD, post-traumatic stress disorder, where you've had some kind of a trauma, they've now included depression as part of that diagnosis in the DSM-5. So when is it that someone's depression is too much to do the EMDR at that time?
That's not a rule out. It's not as so this is where it gets a little tricky. It's not a treatment that was designed to treat depression. It was designed to treat trauma and anxiety. And that's where its primary first evidentiary base lies. Now there's
so you're focusing on that when they come to you, but if they happen to have depression, we noted they're getting treatments, maybe medications or cognitive behavioral therapy or something.
Now, what happens a lot of times, though, is when you treat the trauma, you find a lot of other things clear up: the depression, the anxiety, the low self-esteem, all those conditions, the ability to concentrate.
So, in other words, that the trauma is like a bottleneck for them.
The very first guy I ever worked with, I did a 10-month psychotraumatology internship with Dr. Lou Tennant, who Bessel van der Kolk, by the way, called one of the great minds of the 20th century.
Wow.
Right. So, I mean, Dr. Tennant was like ahead of his time.
He was a psychologist, or
he was a psychiatrist, and his wife, Linda Gant, has a PhD in art therapy research.
Okay.
So that's a power couple for sure. Linda's still alive. I talk to Linda, usually once a year. But Dr. Tennant, Lou, would always say, and Linda said this too, like, first just treat the trauma and then see what's left. Right. Because trauma treatment, if done properly, the way Lou is doing it, the way we're doing it with EMDR, is a form of grief treatment. It's not a psychodynamic treatment. It's not primarily a talk therapy. Sometimes there's not a lot of talking at all. Sometimes when you're doing the dual stimulation, people are just feeling it move around their body. Sometimes people will be like, oh, I feel this tension in my chest. That's the kinesthetic thing. Some people work more intellectually, but some people, they just go like, oh, wait, it's moving. It's kind of spreading out now. Oh, wait, it's kind of sinking into my stomach, like, oh, it's kind of lightning. But my hands are tingling. But, so some people just work kinesthetically through this trauma, which our body kind of holds on to. Right. So,
yeah. And that's interesting because, our motto here at Atlas Psychiatry is getting people all the way well, in that they come to us and perhaps they're not suicidal like they had been before they started an antidepressant, but they're just not well. They're not functioning so well. Right. They're not kind of crushing it in life as they want to be. So I think a lot of these folks, just like you're saying, is they haven't had the trauma treatment, and it's the missing key to their success. So, what you're saying makes perfect sense. Treat the trauma first and then see what's left. Maybe they have ADHD or something in the background, but you can't really get to that because they have so much anxiety.
They can't attend anyway, right?
Yeah,
that's exactly right. So, I'm sorry.
Let me ask you, so you've been practicing as a therapist for 30 years. At what point did you say, I'm going to try this thing out called EMDR and get trained for it? And where were you
I was in Michigan. I had just been hired to work for, we had just moved to Michigan, been hired to work for a federally qualified health center. They had half a therapist at one of their facilities. They did medical, dental, and behavioral health. That was the model. And they worked with all comers. Like, we had people with, great insurance, people who were self-pay, and people who didn't even have a social security number, like migrant farmers and people like that. So it was kind of a take all comers sort of thing. And one of the physicians there was like, we really ought to get someone trained in this EMDR thing. I had been exposed to it a little bit earlier through an early mentor, but I'd never been trained in it. So I was asked, I was new there. I was just billing a caseload. They were like, hey, do you want to go do this training? I was like, yeah, sure.
And what was what type of therapy would you deploy prior to learning EMDR? What were you doing? What techniques were you using?
I had been trained in trauma-focused CBT. So I used trauma-focused CBT. I had been trained in this ITR, this intensive trauma recovery. I had been trained earlier by Lou in a process that he called recursive anamnesis. I had learned a whole bunch of different CBTs, like CBT in schools and trauma-focused CBT, and there are lots of different.
A ton of stuff. Yeah. So this was just like the cherry on the top for you in a way.
It was kind of, no, I was skeptical. I was really skeptical. I was like, okay, you're going to wave your fingers and I'm mind tricked, like, live long and prosper. It all seemed a little hokey or science fiction or something. But I was like, sure, a week in Lexington, why not, So, but once I got there, I was just blown away. And part of it was by my own experience of it. Like I processed 3 traumatic experiences from my earlier life that would have
you had EMDR done. You had EMDR done to you.
Yeah, that's part of the training, right?
Okay.
Because you're doing.
Tell us about what was that like?
It was. I felt like I had just done with each of those sessions. I felt like I had just done 6 months worth of psychotherapy.
Wow.
I was just like, because I had already, I started working on my trauma therapy more than 30 years ago, right?
Yeah.
So I went through it the old-fashioned way, where you just told all the stories, you drug everything out of the closet in excruciating detail, you looked at all of it, you rearranged it, and then you put it back in the closet and you threw some stuff away, and it took forever and it hurt so much that you'd quit and come back and quit and come back.
Right.
Right. So experiencing it this way, it was like, damn, why didn't I find this 30 years ago?
So when you left that, you were probably pretty excited to, use it as a treatment for all these people that you've been meeting.
Yeah. And they encourage you to just go back and just start using it. And Roy Keesling, the way he teaches it and the way Carol Lovell teaches it, they really focus on also integration into whatever your skill set already is, right? So like, for instance, people who are doing play therapy, they were like, good, keep doing play therapy. And while you're at it, we can get these little buzzies and put it in kids' socks, and they'll sit there and have this dual stimulation while they're doing some artwork about the bad thing that happened.
How young can a patient be for using EMDR?
I'm not sure. I can't accurately say if the EMDR International Association has set a lower limit, but I know a lot of people use it with children. It is also one of only 2 evidence-based practices for trauma treatment in children.
Okay.
The other being trauma-focused CBT.
Okay. And are there times, what are the reasons where maybe patients won't be able to do the EMDR? Can you think of times when people kind of engage in it and then they can't do it, or they don't get better? And can you speak about that?
Yeah, sometimes people just simply aren't ready. Sometimes people, so because we're talking about trauma is something that happened to you that you didn't ask for. So the last thing we're going to do is do anything to anybody that they don't ask for. We're not, never want to replicate the trauma, right? So if a person starts the eye movement and finds it unsettling, they've already been coached in the preparation stage that they can just stop, and then you stop and you see, sometimes it's just a stuck point, but sometimes they're like, I don't like this. This doesn't feel good to me. I don't like this. And then you just give them choices like, well, we can try the tapping. We can not do it. We can, move to a different form of trauma therapy. We can just work on today's problems. I mean, there are lots of different things we can do that can be very helpful in psychotherapy. Honestly, I've only had it happen twice. In 5 or 6 years I've been doing EMDR now, I've only had it happen twice.
Yeah, and I think we've had a patient who put it on hold because I think something externally happened. while they were doing EMDR. Like it was just a bad time. Something had happened personally that they were like, hey, this isn't the best time, but they want to return and recommit. So it's just a pause. It's not a total stop.
Yeah. Well, see, that's the cool thing. Like, especially people with that childhood trauma, it's not just one trauma. Sometimes the big T trauma gets treated really quite quickly. The more complex trauma, the stories get woven together, and it's in the past, and they're like layers. It's like not just a splinter that we're pulling out now. It's been in there a while, and it's all infected, and it's all, and you're gonna have to get in there a little deeper to get it out. So with that childhood trauma, sometimes you get so far and you feel a certain sense of like, okay, that really helped, and I'm going to pause now. And people often do come back later and say, you know what, there's this other thing, or sometimes something new happens. Well, so it's okay if people need to pause, because each unit is a finite unit. Like, you're doing the preparation, but when you do the actual trauma processing, the desensitization stage, right? When we get to the desensitization stage, where we're using bilateral stimulation, we have to, before our session is done, we have to have it wrapped up for that person, right? Because once they do the desensitization and we install the better thought, we use the same bilateral stimulation to install the more adaptive thought. It's more true, it's more helpful, it's a healthier way of thinking about ourselves and about our world. Once we install that, then we have them kind of do a scan and see if they still have this distress somewhere in their body. If they do, we help them move through that, right? Because we have to get to closure. We have to get to the place where the patient is okay, absolutely okay to walk out the door.
Yeah, because it loosens things up, and psychologically you're shifting things around.
That's right. And we want to make sure that people are present. So we spend a little time at the end saying like, okay, how was that? And then we have them go through some grounding exercises that we already taught them earlier. Make sure we'll ask them things like, what are you making for dinner tonight? Or what are you going to do when you leave here? Just to get them back to think about the real world.
The reality.
Yeah. So we got to make sure they're right and ready to leave that session. So that's our contract with that person, right? It's like, we're not going to let you go out the door in a wrong state of mind.
Well, I haven't done any EMDR myself, and I'm going to have to schedule an appointment with you, I think
you should. It's and the thing too that's really cool is the person that's doing the patient is really in charge, because they get to pick which trauma they're ready to process next. And very often their intuitive system tells them what's next. They just know. They just know. And that's another thing we want to do, is always support that knowing, right? Because when people experience trauma, they stop learning to trust that, their own sense of wellness and safety and wholeness and confidence. And so we're helping to reinstill that too. That sense of like, no, you're in charge of this. You know what you need.
What about folks listening where they say, well, yeah, I've had some trauma, but I probably don't need it. I'm probably okay. Like, how would they know to give us a ring and say, yeah, I actually want to try this thing out?
A lot of times,
what are some metrics they could use to help them make that decision?
Well, I'm going to go back to Francine Shapiro's dictionary definition of trauma. If something happened in your past, like trauma is not the same for everybody. Some people like to jump out of airplanes. Me personally, no, thank you.
Right.
It sounds terrifying, right? So everyone's trauma is different. But I would say, if you have something from your history that is not helping you, it's hurting you, it's making it difficult to live life, you're struggling with it, it's affecting your current relationships, your current work, your current life activities, your activities of daily, your education, then come get some treatment for that. Get rid of that stuck thing so that you can grow new and better.
And what if they don't know? What if they don't know if that particular trauma is in fact the thing that's causing them, preventing them from succeeding in life now?
Well, once again, we also use it just as liberally for anxiety and for panic disorders. So I would say if you're feeling experiencing anxiety, you're experiencing panic, you're having trouble paying attention, even if it's something that happened a long time ago, sometimes, post-traumatic stress disorder has a delayed onset.
Yeah.
Right. That's one of the modifiers. It can kind of, it's
unusual. It's unusual, but very interesting when it happens, and tricky to piece that together when it pops up, a couple years later or longer.
Right. But so what we would do, for instance, if someone had a trauma history, but they're coming in really because it's anxiety, it's panic, it's or I would say, even intractable depression, right? Like you have a lot of great ways that you treat depression, right? You've got a lot of tools in your toolbox, but if those tools aren't getting it done, then this is a different tool that approaches it a different way.
Yeah, and usually we would make the referral to some kind of trauma treatment earlier if there's enough trauma and alongside depression, because I think it's a less expensive kind of treatment, less side effects with EMDR, of course.
Yeah. Well, so if someone's presenting with the panic or the anxiety or something that's not specifically trauma, there are protocols for you don't have to have that picture of the traumatic thing that happened. You can just start from that feeling in the body. Some people are just like, oh, my chest gets tight and I feel like I'm having a heart attack. And you can start with that and just desensitize that. Sometimes it'll drift you back to the traumatic experience. Sometimes you never do know what the traumatic experience was because so much of the processing happens right inside the brain across the corpus callosum.
So anyone could come to you to be evaluated and to discuss, hey, maybe this would work for me or not. And that's a way they could find out. I think what we should do is link the ACE, the Adverse Childhood Experiences form, I think, to the description below our video here, and maybe some.
Oh, that's a great idea. Yeah.
Folks. Because I don't think actually it was I was in practice for a few years, and then we started using it more and more because it was so indicative of someone's diagnosis and so assistive into cracking the code for someone's mental health.
Right. Yeah. No, I think that's very helpful. And also I would say, Francine Shapiro's books, she's got a couple. One is Getting Past Your Past. One is just called EMDR. And she talks a lot more about the history and the development. And she elucidates all those 8 stages, which we've
Getting Past Your Past is the book that a patient might read?
Is a book that a patient might read, or even EMDR is a book that a patient might read. Now, there's some other people that are not Francine Shapiro, who are not necessarily a part of the EMDR International Association that have written, stuff on like, do your own EMDR and stuff like that. But I would so not recommend that, because when we're touching trauma, there's always that possibility that someone's have an abreaction and just you want to be doing this with a professional.
Absolutely.
So make sure whatever you read or whatever you look at, whatever website, whatever video, whatever, you want to look for this stuff that's EMDR-IA.
Yeah, and I would say as a disclaimer to anybody listening, if you have any past trauma and you need help, definitely talk to either your doctor, your therapist, or give us a call to be evaluated, so you're not going it alone.
Yes.
And this is not specific therapy advice for anybody in particular. They would have to speak to somebody to know what their situation is.
Right. Yeah. Exactly.
Well, fascinating, Gary. This is just a wonderful deep dive to figure what EMDR is all about and trauma. I think it's going to help a lot of people clarify, what trauma is or had been in their life and what they could do about it.
Mm-hmm.
Thank you for the
I would
wealth of
say
information.
also link this to the video, the little short video that I did where I explained a little bit more of that adaptive information processing system.
Oh, the prior video you did? Sure.
The prior video, this was more about trauma than about EMDR specifically, but
yeah, absolutely. Well, any parting words before we hop off here?
The really important thing, the thing that was really important to Francine Shapiro, the thing that's really important to me is for people to know that trauma is treatable. It's absolutely treatable. We haven't always had great treatments in the past, but we have a really good treatment for trauma now that moves people through it really quite quickly and with a lot less pain and a lot less reliving of old hurts. So if you've tried trauma treatment before, if you've had unsuccessful attempts, find an EMDR therapist and give this a go. It's really a different kind of approach. It's not a lot of talking. It happens internally, and it's really powerful. So I just want people to know there's hope in getting past their past.
Absolutely. Thank you so much.
Absolutely.
All right. See you later.
Thank you, Dr. Nick Pejic.
Right. Okay. You're welcome.